I'm now delighted to introduce today's keynote speaker, Lacey Bryant. Until 2024, Sue was the Chief Knowledge Officer of the NHS in England, following a formidable career across a range of health information and library services in the sector. Sue is now a knowledge mobilisation consultant, a coach, visiting professor in knowledge and information mobilisation at Manchester Metropolitan University, chair of the National Health and Digital Literacy Partnership, of which she's a founding member, immediate past president of CILIP, and a regular volunteer supporting reading at her local primary school. Sue's work remains focused on how knowledge, information and literacy impact health inequalities. So it's really wonderful to welcome her here today to present today's keynote on poor health literacy as a predictor of ill health.
At which point my mic is going to be switched on. What magic thing? Oh, a magic thing. You're green. Good morning. So I have my opening sentence ready, but to follow these three presentations, I think I need to say some other things. So first of all, what a wonderful tribute to former colleagues. And actually, what a marker of, you know, I knew LILAC was I knew the Information Library Group and LILAC was a very vibrant community, but the sheer warmth of this community has come across, and I think, you know, what a powerful connector that is, and what a powerful community, and how fortunate are we as a profession to build networks of this kind, and how valuable they are. So thank you. And then following on from the first two presentations, you know, I'd like to sort of bring with us that sense of urgency to the topics that we'll be covering through conference that I think Mary Vincent started to point to. This is an urgent situation. We are going to produce a just society with any form of equity within it. And you know, one of the respondents to Michelle's work said, well, we need to get on with this or I'm going to be dead. I started my work on health literacy in, well, roughly 1987 with the launch of a telephone information service called Croydon Healthline. And I've spent the last 40 years trying to bring more and more people onto the same mission, because otherwise I am going to be dead before we see some real progress. And at the moment, we're seeing this issue getting bigger, not smaller. So I'll start to move into what I was actually going to say. So with a first sentence, really, and then I'll move across to my script. By the way, if people find they're getting neck ache during this or they need to move in, you know, just shuffle in the other seats, I won't mind. Look, poor health literacy so significantly limits an individual's ability to use and understand information to make choices about health and care that it is a predictor of ill health. Yet it often goes undetected, and its impact is both underestimated and unaddressed. So I'm on a mission to bring health literacy to the front of your minds amidst what is an exciting and jam-packed conference programme. And of course, thank you for inviting me to talk with you. It is a predictor of ill health, and my mission is to lift health literacy out from under the radar and to consider actions we may take to improve levels of health literacy. And while I'm on this slide, you can see the QR code through which you can submit questions, and it will show once or twice. But I've never walked through a door which said, "Ask Sue Lacey Bryant questions" before. And in the broadest of senses, the answer is 42. But I will do my very best today as we go along. Okay, so look, travelling to Sheffield and later, anyone can hear about my journey to Sheffield. It was pretty traumatic. But travelling to Sheffield, it occurred to me that we all take our literacy for granted as we make our way through the station and as we make our way through life day to day. Functional literacy, meaning a person's reading and writing skills, that they're sufficient to cope with everyday life. For instance, to read signs. That's our starting point for health literacy. So, as information professionals, we all know that our fellow academics, educators, practitioners, everyone in this room is short of time, and being here is a commitment. And so we are wise to cut to the quick, and health librarians are always encouraged to start with the bottom line. So I'm going to start with the top 3 messages, on which I'll be expanding through the day. I'll share some of the evidence on the impact of low levels of health literacy, and I'll touch on the link with health inequalities. It's a field which is attracting more and more activity in literature, actually. So that's been interesting as I've been writing this over the last few weeks, as more stuff has come in. I'm going to signpost the work of the National Health and Digital Literacy Partnership, which I instigated and which I'm privileged to continue to share, and the experience of the Complete Care Communities programme, for which I'm a mentor, for which I'm a volunteer. And I aim to land this session by sharing some really practical suggestions for you to draw on as you return to work. So, the bottom line, the top 3 takeaways. Health literacy is a determinant of health in its own right. It's a stronger predictor of an individual's health than income, employment status, education level, and racial or ethnic group. But the good news is that a person's literacy, language, and numeracy are not fixed. They can be improved, and health literacy is likewise an amenable determinant of health. If anybody happens to follow me on X or Blue Sky, there's been a bit of dialogue going on with Michael Rosen, Alison Wheeler, who used to be on the CILIP board as a trustee, and she's volunteering with adults who can't read. Michael Rosen is calling for a campaign to assist with that, because adult literacy is where we even start our journey towards health literacy. So the most important takeaway is we can do something about it, guys. We can think about our own skills, we can think about how we can upskill others, we can think about how organisations are health literacy friendly or not. Pop into your local hospital and follow the signs and just see what you think. Then try it in your own organisation. So, starting with what we know about adult literacy, the UK faces a huge challenge. 1 in 6 adults in England are estimated to have very low literacy, which means they may struggle with longer texts and unfamiliar topics. These individuals experience negative, that's an understatement, negative impacts on personal relationships, well-being, health, a greater risk of unemployment, being in a low-paid job. Now, the National Literacy Trust is really clear. If more action is not taken to tackle low literacy in adults, we risk perpetuating and reinforcing an intergenerational cycle of disadvantage. And I'm old enough to tell you that's true. So, a quick show of hands. How many of you are conscious that you have met an adult who is illiterate? Yeah. How many of you are not? So I invite you to look and notice, all of us, because we're missing 1 in 6 of our fellow humans. So illiteracy is under the radar, and I'm going to read this quotation. The reason illiteracy often disappears under the radar is because by its very nature it is exclusionary. We talk a lot about inclusion in our work, but this is our first point of exclusion. Most, if not all, modes of communication require some literacy skills. Texting, looking up a name in a mobile phone to make a call, using Google Maps to find out where you're going. Now, actually, I've got no sense of direction, and Google Maps is of limited help to me, but that's another kind of awareness and navigational problems. I can navigate on the net, though. So, you know, this is before the enormous challenges of doing things like applying for a job or applying for benefits or managing our health. You know, I don't know how easy you're finding eConsult, and going through the various questions. I had the privilege of working with some adults with learning disability while I was working within the NHS, and you want to listen to their account of trying to get through that first encounter to get to an appointment, or dealing with GP receptionists who want to refer everyone back to that portal. So people who can't read and write are easy to forget about entirely, but when reading ability really is so often drawn on class and income lines, we must cast the net wider to be more tolerant of and helpful to people who find it hard to utilise words for their benefit. Lovely to see that oral history presentation, I must say. So thinking about the journey we must take as individuals from literacy to health literacy, you can see here the skill sets on which we need to build. So starting at that end with functional literacy, as I've been talking about, the skills of reading, writing and meaning making. That's the starting point. And as more health information, so functional literacy, you can see the definition there, the ability to read. I've given you the source of the definitions I've used because I don't want to debate those, but you can through conference. But the ability to read, write, speak and listen in a way that lets us communicate effectively and make sense of the world. But as more health information, and clearly that's where I'm coming from, but it applies to banking, pretty much anything else, travel. As more health information is shared via digital platforms, we also need to remember that 1 in 20 people remain without internet access at home, and that's 1 in 5 for people aged over 75. And if you live in certain parts of the country, your connectivity is rubbish as well. So you need to be within that sort of 1 mile of your main centre. So, but you know, again, that's having those capabilities that fit us to be able to operate in a digital society are really key. And again, fundamental building blocks for health literacy. Information literacy, your definitions, I think, the ability to think critically and make balanced judgments about any information we find and use. And I'm guessing that any one of us might have found that challenging when we look at health information for ourselves or for our loved ones. So then we come here to health literacy, having the appropriate skills, knowledge, understanding, and confidence to access, understand, evaluate, use and then navigate health and social care information and social care and health medical services. Just to note here that the ability to read itself is not an indicator of functional health literacy. People may still struggle to understand and critically assess health information. And my thanks here to Ruth Carlisle. Now, many of you will know Ruth, a former colleague who has allowed me to use and adapt this slide. And she's doing a session for the Federation of Informatics Professionals, which I think is really useful on health literacy tools that you can use to develop your work. So how does health literacy manifest itself? Well, there are different ways of looking at this in terms of, putting numbers to it. These data are from a population study, part of the annual British Social Attitude Survey in 2018. And they give us a national baseline. So you'll have read that while I've been taking my drink, but roughly 1 in 5 people have had some level of difficulty reading and understanding written health information, and a little bit more, 23% of respondents to this survey had some level of difficulty discussing health concerns with healthcare providers. So we've got about 1 in 5 people who have the skills to complete a written questionnaire are finding it difficult to get across to a health professional what they want to say about their health, and are finding it difficult to understand written information that they're given by a health professional. If you look at the lens through, look at the problem through another lens, Jill Rowlands and team looked at the readability of a sample of information materials about health to assess the literacy and numeracy skills required to understand them. That tells us that 43% of adults can't understand word-based information sufficiently to make a health choice. And if you add numbers and think how much of health information and how many medical conditions require numbers, diabetes, thyroid conditions, just weight, anything. Huge problems. And when it comes to medication, there are really obvious risks here where people can't understand the labels, they can't follow simple instructions on a medicine bottle. That's what the language says, simple instructions. Are there simple instructions on a medicine bottle? You might read some and see if you think there are. A couple of years ago, I was at a conference and a health library manager said to me she'd just done an audit of the information, the patient information produced in their trust. And she said, do you want to guess what the information age is? I'm not going to make us guess. It was over 18. This stuff had got worse and worse and worse. You now need a reading age of 18 to be able to study material at her trust when she started. That's an incredibly useful thing to do. Just look at that kind of information. So there is a significant mismatch between population health literacy, indeed population literacy, and the complexity of health information. But for genuine shared decision making, people need to be supported to make decisions, enabled, equipped to make decisions that are right for them through discussions that take into account their skills in this area. So here's some of the geodata that illustrates, if you like, the geography of the health literacy challenge, and there is a bit of a geography to it. This is a tool commissioned by my former team, the National NHS Knowledge and Library Services team at NHS England, produced by the University of Southampton. It shows the prevalence estimates for local authorities for both health literacy and for numeracy. And there is considerable, there's a heat map, of course, and you can see considerable variation across the country. People living in the areas of greatest socioeconomic disadvantage and those from Black and Asian communities have the lowest levels of health literacy. So if we're going to take forward interventions, we want them to improve health literacy. It will be best if we can target those with lower levels of education, those living in the most deprived areas, and those with a limiting health condition, long-term health condition, or disability. So I particularly like the Canberra Health Hub. It's a very person-centred site focused on the needs of individuals, and it builds on that picture of who needs higher levels of skills and support to gain more knowledge, build more skills, and to be motivated and feel confident. So, and this applies to people when they're facing multiple complex health conditions, and the number of people in the country who've got more than one health condition is growing very significantly. So if you're facing multiple conditions rather than you've got straightforward health needs, if your life is complicated by conflicting priorities, demands and issues compared to when your life is in a period of stability, that can be anything. People experiencing domestic violence, people who are simply ill, people who are bereaved, people who are moving house, people who have lost their job. It definitely applies when people are most comfortable speaking a language other than English. So it's a real challenge. In situations where social networks and pressures create barriers for them rather than where they're really supported, in situations where their cultural and religious beliefs are different to the norms of the people around them, where our beliefs are different to the understanding of the health and cultural norm of the health system. That can manifest itself in many ways. And when health systems are disjointed, bureaucratic, technical and unfriendly, rather than well-connected and user-friendly. So you make your own judgments about your own trusts and your own general practice and all the people with whom you're working or engaging as a patient. But there is a strong evidence base, and there is a strong evidence base for the really detrimental impact of poor health literacy on individuals. Compared with the general population, people in this position use fewer preventative services, such as cancer screening or flu vaccinations. They'll have less recall and adherence to medical instructions, medication, healthcare regimes. They're less likely to successfully manage a long-term condition, and they're more likely to struggle to manage their health and well-being and that of their family. And so they're at increased risk of developing multiple health problems which they need more help. They're 1.5 to 3 times more likely to experience increased hospitalisation or death, and more likely to have depression. So sometimes when I reel off numbers like these, you know, the first ones, we used to go in, when I worked in the health service, we always went in with that 43-61 figure, and I started taking that back to the 1 in 5, because I think if you're a health professional and you're going to work every day, the scale of this communication challenge is just immense. We mustn't sit here and think, well, they need to communicate better, because what a job. They've got people like you coming in the room 1 minute, an Oxford Don the next, and then someone whose health literacy won't be evident, and maybe even their literacy level won't be evident. So these are enormous challenges, and we need to get behind people in schools and teachers and so on. You're looking at your watch already, that's a really bad sign. I'm teasing. So poor health literacy is associated with poor health outcomes, and I'm very passionate about health inequalities. The reason I joined the health service and the reason that I brought my skills into this sector rather than sectors I'd worked in previously was I'd grown up in Medway towns, and I know what disadvantage and inequity looks like. So health literacy is related to health outcomes and service use. It's central to health inequalities because disadvantaged and vulnerable groups, particularly those with a really challenged socioeconomic background, disabled people, older people, and people from ethnic minority groups are really being hit by so many factors in our society. People with, and then the other way round, people with long-term conditions, although it's, the correlation is, there probably is a correlation, there's definitely an association. People with long-term conditions, including depression, diabetes, and heart, kidney, and musculoskeletal diseases, are more likely to have health literacy, limited health literacy. So again, independent of all other risk factors, including age, education, gender, and so on, limited health literacy predicts poor diet, smoking, a lack of physical activity, all behaviours that are detrimental to our health, and each linked with an increased risk of morbidity and premature death. It's not surprising I've been banging on about this for 40 years, is it? So now, tackling inequalities is high on the agenda for health and care services, and while improving health literacy alone will not achieve health equity, my proposition is that it is critical and needs to be incorporated as a central aspect of initiatives to address inequalities and into the thinking and the work that we take forward and the research that we take forward. So I volunteered with the Complete Care Community Programme for a couple of years. And it's interesting, as I just mentioned research, and it was through the process of the evaluation of that programme that health literacy emerged as an important factor. Not that anyone involved in it, not anyone in the sites, not anyone in the communities, and not the academic research team, none of them would have used that terminology, actually, unless I had joined the team. So that was really helpful. They've worked with 65 sites. They're all communities looking to reduce health inequalities through looking through the lens of wider inequalities of health. And it came to the fore as a key theme from the analysis of interviews with service users. By chance, there were 65 interviews with service users too. And what came across was that people using our health and care services are confused. It's confusing. They don't know where to turn to within the system generally. And the same service users expressed relief and thanks around the initiatives that they worked with, that they'd reached out to them and were helping them by signposting them to other available services, to which service to use. Figure 1 shows the 3 themes that emerged. So there were practical issues for patients about how to access services. There was a need for greater knowledge and awareness amongst healthcare professionals, and a need for staff to have a better understanding of the circumstances of individuals. That report's going to be published in the next 3 or 4 months. So this is the kind of poster you see. Actually, there were some that were vastly more confusing than this, and look them up afterwards. But, you know, it's so challenging that we all need to be told which one to go to when, and you may well ring one of these services up and being told you need to go to another one, but it's Saturday, whatever it is. So people with low levels of health literacy definitely find it more difficult to access appropriate health services. And as I've said, I think lots of us can struggle with that. Don't forget, you're ringing these services when you're anxious, unwell, in pain, worried about someone else. And that's why the NHS has so many posters of this kind. Patients with limited health literacy make more use of A&E services, accident and emergency, and they generally enter the system when they are sicker. And once they're in hospital, they stay longer. Their inpatient stay is longer, and they have less effective communication with the people looking after them and trying to help them get discharged. And that's partly because they're less likely to engage in active discussion about their options, their health options, and that possibly also leads to their health needs being hidden. So for patients, so there's a cost to all this. There's an emotional cost, there are burdens on everyone. So for patients, health issues often involve additional expenses, prescription charges, travel costs to and from appointments, parking, loss of earnings. Very difficult now to get leave, even to go to a hospital appointment, certainly in my son's community healthcare trust where he works. So along with the awful burden of health literacy on individuals, it is a significant burden on hospitals and the health systems. It is in every sense an agenda we cannot afford to ignore. The rates are associated, low health literacy rates are associated with higher financial costs for hospital trusts, community trusts. It is estimated to account for 5% of national health spending, owing to the interrelation between health literacy and unhealthy lifestyles, low uptake of vaccinations and screening, incorrect and inappropriate use of medication, increased time in hospital, increased use of hospital services. Equally, it's linked to poor self-management, self-care with the long-term conditions, and in turn to higher overall healthcare costs. And there's some research which suggests that emergency readmissions could be avoided if patients were provided with better communication and support at discharge. So, you know, I'm really pleased to see that NHS Providers, which is the membership body for all the different sorts of healthcare trusts, from hospitals to ambulances, has become much more alert to these issues. And we also see NHS England placing more emphasis on health literacy. Since I no longer work for any of these organisations, I might add, about time. And of course, the health literacy of individuals is influenced by the context in which they live and are managing their health. So I want to bring in the case for the whole information environment that we experience being understood as a social and cultural determinant of health. Our information environment is the aggregate of the people, the organisations, the systems that collect, process, disseminate or act on information. It's essentially the condition in which we're born, grow, work, live and age. And it's one of the non-medical factors that significantly influences health-related beliefs, behaviours and outcomes. We all operate within an information environment. It was good to hear the first presentation start to reflect to reflect that. And that environment in which we all operate holds varying levels of true and false information, rumour, news, misinformation and disinformation. And a chunk of that is peddled by quacks and charlatans and further fuelled by AI. Yeah, and that first definition I gave you was from the American National Institute of Science and Technology, by the way, that one of the information environment. Just go back, sorry. So with Palmer and Gorman, whose paper I recommend you read, I want to see the information environment recognised as a social determinant of health and incorporated into relevant public health models. They concluded that information environments differ with respect to the nature and prevalence of misinformation, that groups who inhabit information environments with greater amounts of ideologically friendly misinformation are more likely to endorse misinformation. When those environments contain substantial amounts of health-related misinformation, we'd all expect to see different health-related effects compared to groups who inhabit different information environments. So recognising the information environment itself as a major social determinant of health is critical, in my view, to addressing health inequalities, because we need policy that can combat misinformation, promote health equity, and improve population health outcomes that takes this concept into account and takes it really seriously. So what harm can a dose of misinformation do, we ask ourselves? Does it really matter? Well, a couple of different studies here. So 2018 MIT study starting to talk about, well, what they found was that misinformation diffuses faster, farther, deeper and more broadly than the truth in all categories of information, whatever the topic. And false stories are 70% more likely to be retweeted than true ones. There's a thing called the Edelman Trust Barometer. You may have come across it, 2025 version. It says 58%. So you talk about 18 to 34-year-olds in the States regretted decisions they'd made about their health because they'd identified that this was now misinformation coming from social media influencers without medical qualifications. There's probably a separate line for social media influencers with medical qualifications who want to sell you products you may not need. In a recent cross-sectional survey, and this data is coming out from SCARI, which is the Centre Self-Care Something Research Unit at Imperial. That's coming out this summer. Now, they've done a survey in which 82% of people reported that they'd encountered misinformation, misleading information in the previous 6 months, and that exposure to pharmaceutical and health misinformation had clear impacts on their behaviour. And that was termed in terms of delaying to seek professional medical care. And that applied even after you adjusted for age, sex, education, ethnicity, and urbanicity. The more frequent the dose, the bigger the problem. So the greater the delay, and those who are exposed to content weekly delayed longer than those seeing misinformation monthly or just once or twice. And they report, and I haven't read, the full paper's not out, I've just read the highlights from a preprint. They report that traditional health literacy skills helped identify some forms of misinformation, but were insufficient against AI-enabled tactics. So we need to keep an eye out for that paper. So here we are, February, I'm preparing this paper, and in February comes out the government's newly published Media Literacy Action Plan. Obviously, media literacy plays into all this. It supports that concept. I'm really thrilled because they haven't heard the lecture and they've not seen my draft notes. It supports a healthy information environment. because they recognise that by helping people to tell the difference between accurate information and other types of information is going to make a real difference. Importance of easy access to clear and trusted information. Trust is an important word. I imagine we'll hear it a lot through this conference. And remember that librarians are in the top 3 most trusted professions. We come in after nurses and pilots, and I kind of don't mind pilots being ahead of us on a personal note. So I've always felt okay about that. So, but that trusted information, keeping people safe from misleading information, and the government says it will make sure that high quality, accurate information and news is available and easy for people to access. And clearly the NHS website is going to be a key resource from that. Now they base their, they base the plan, the plan lists key actions, including work by the Department for Health and Social Security, UKHSA, public health organisations. And the approach is based on these 3 principles: supporting people through trusted places like schools, libraries, services, etc. Emphasising the importance of tailored support. You know, one size does not fit all in this challenge, and that is, of course, part of the challenge that I've seen over the years. Clearly making use of existing tools, partnerships and ways of reaching people. They want it to be evidence-led and evidence-based, sharing what works, and all the academics in the room and all the researchers in the room and all the librarians in the room can help with that, keeping a watch on this evidence as it comes through and disseminating it to people, to everyone. One of their philosophies is around helping everyone play their part: industry, education, the voluntary sector, and don't forget families. So, it's really good to see that commitment to evidence-led, and I just wanted to flash up the work of the Health Equity Evidence Centre at Queen Mary University in London. This is a piece of work from them in December 2024. It answers the question, what works to improve health and digital literacy in disadvantaged groups? They do very rapid work. They use machine learning. I'm very sceptical about AI as to whether there is any, but they definitely use machine learning. Oh, I slipped that in, didn't I? But they definitely use machine learning to support those briefings. Now, they came up with 10 questions. I've just selected 6 of those recommendations to mention here to this more generic audience. I'm going to give you a moment to just read those because that gives me a chance to take a drink. So it is good to see the role that the role of library services made it into the list of recommendations, although it's frustrating that we can't offer stronger evidence. Actually, this came up in so many of the things that I read or reread preparing for this. The research base does need to be stronger. And of course, you won't be surprised that isolating the contribution of librarians in the context of multi-component interventions is difficult. And I've always found that any intervention you do that's successful from a library perspective, you find there's loads of other people who feel they are able to claim it not long after you proceed, but maybe that's just me. So, good evidence that improving the health literacy of individuals makes a difference. We can improve the knowledge and skills. The most successful interventions, and I know I keep saying this, but I'm going to carry on saying it, there aren't quick fixes. You've got to have tailored, thoughtful approaches. So, tailored information using a variety of multimedia tools, focusing on upskilling and empowering users, and I'm sure lots of us do that. Then the last bit, and are delivered over a sustained period of time. So once and done doesn't do it. So improved health literacy increases health knowledge, improves mental health, promotes healthy lifestyle changes, improves engagement. It's just a reverse of everything that I said at the beginning. Improves confidence and self-esteem, makes it easier to comply with medical advice and medication advice, equips people to, get into the health services in the first place, and empowers people to manage their long-term health conditions, reducing the severity of disease. Anything we do is of value to impact on these decisions. So we come to the concept of truth decay, librarians and the fight against truth decay. This is a report came out of the RAND Corporation 2018. Barack Obama, not president then, put it on his summer reading list, which was helpful. And of all the professions, this report says, librarians are probably best equipped to tackle truth decay by distinguishing between fact and opinion, assessing reliability of sources, identifying potential sources of objective information. And perhaps most importantly, librarians have an opportunity to transfer those skills to others, young to old, old to young, and to help them navigate the information landscape and recognise cognitive biases. So let me turn to the health literacy framework from the network of the National Library of Medicine, which NLM uses to identify topics for training and activities or programmes that support health literacy. It acknowledges the role of individuals and organisations and the strong influence of overarching societal and cultural factors. The companion guide includes a breakdown of the framework structure, and you can look into this. But it talks about the many ways in different types of organisations can make a difference, and I've used that as a frame for the last section of my presentation. Have I got another 15 minutes? Yeah? Okay, carry on. So in that framework, information is one of the, I'll just go back and name them. So you've got information itself, the professions, organisations, individuals, and then those social and cultural determinants of health. So if we think about information, first of all, I took a study which gives an example on patient information on osteoporosis as one example, funded by the National Institute of Healthcare Research. And it looked into the readability of information in this field, which is described as a silent epidemic of which many people are not fully aware. It talks about all those items, every sample, used unnecessary technical language. Most of the information was too complex for people to understand. None of the resources met UK standards for health information, for information on ease of reading. UK standards on ease of reading. And some of those materials were actively misleading, and some of it didn't present a balanced picture. One of the really important things we stress in healthcare, balanced assessments of different types and options of treatment. So, really, really challenging, and could well stop people either not taking medicines offered or stopping treatment that can be really effective. From the NIHR review, they went on to do some work then. I think they were so shocked by those findings, actually, that they went on to do some work around trying to give some easy messages about how you can create good quality patient information. So use plain language, avoid technical jargon, say who it's for, explain how reliable the evidence is, focus on personal benefits. Digital platforms get information out there to many people, but the information also needs to be accessible online, offline. Images, videos, animations are especially important for groups who need extra support to understand this information. We've talked about who those are. So really important that we remember that a picture is worth 1,000 words. Now, given 15 minutes in small groups, 10 minutes, 5 minutes in small groups, I've no doubt any of you would have come up with the similar list to NLM, but it still is a useful checklist of the features of information that we need to consider when we want to better support people with low health literacy, accessibility, quality, relevance, of course. So if we turn our attention now to community-based organisations and think about what the network recommended. So clearly, librarians and educators in community organisations can play their part, aiming to improve the well-being of residents, focused on local needs. They can organise health education programmes, presentations, events, and from a health, there's a lot of advice through this about forming coalitions to advocate, advocate and monitor the kind of implementation of programmes and policies that are implemented, that are agreed to advance health literacy. They can train healthcare providers and professionals who provide health information, work with other communicators, and they can connect people who want to take forward these fields so that they can share. The CCC programme I mentioned coined the term language empathy, which extends beyond translation to ensure that conversations occur at the individual's level of comprehension, readiness, emotional readiness, cultural expectation, basically that it aligns with their lived experience. And the programme really found that that improved the patient experience and choices and treatment adherence. So healthcare organisations and healthcare trusts are starting to do work with this. Some trusts are really doing a lot of work with it. They can lead initiatives, often with the library teams as part of that. Definitely agree training policies because all their staff need it. Raising awareness of health literacy as an issue. Using plain language, of course, promoting information standards across the organisation. These things are not coordinated. Hospitals have 12, 14,000, 16,000 staff. It's a big operation trying to get people to take similar approaches to a topic of this kind. And again, promoting it. I definitely recommend that approach to auditing. I mentioned the experience of one of my former colleagues just now. And using the tools. Just use the tools. The NHS readability tool, the Flesch-Kincaid readability tool, to assess that the information that's going out is clear and accessible. And I wanted here to flag this work from NHS providers, as I said, that association, membership association of healthcare providers, who have just produced this guide on becoming a health literate organisation. I'm sure it could be well adapted to any other type of organisation. They describe a health literacy friendly organisation as one that makes it easier for people to navigate, understand and use information and services to take care of their health. Why wouldn't we expect all public services to be doing that? Colleges, universities, again, very similar advice, but think about this in the curricula. Make sure that students, obviously the obvious students, medical students, nursing schools and other relevant fields of study are benefiting from learning about health literacy and communication and techniques. Let's talk about a health communication concentration. So that's cross-cutting across a range of disciplines from public health to comms, media and so on. And again, trying to make sure that a consistent approach is taken over the organisation. And you can hear me again banging on about research, despite the fact that there's a lot of anecdotal evidence and experience evidence and lessons learned type publications. Solid, robust research is more thin on the ground. So I wanted to, of course, in Sheffield, give a flag to this literature review, which comes from SHAR, the Sheffield Centre for Health and Related Research, and it's one example. This one reports that health literacy interventions have potential to affect emergency and primary care use, and we saw that earlier from another study actually. But the evidence base is inconsistent, it says. And this is my opportunity to plug LILAC Information Literacy Award winners. This is from 2022. It's based on surveys and discussions that Alison Horner-Lariche and Barbara Moyes, their work was creating teaching packs focused on evaluating resources, preparing for health appointments and using the right services. Clearly including health literacy in the curricula, having school nurses participate in classes, and training on health literacy, providing students and families with clear, actionable information. I like that word, actionable. We need to use it a lot more in all of our work. So, building up, of course, to researchers and research organisations, clearly opportunities for best practice here, and that starts with creating plain language materials for recruiting people onto research trials, for example, informed consent forms, research summaries, using assessment tools, as I've mentioned, patient participation advisory groups to provide input on the needs and gaps that would help people get involved in research and understand the research. And again, agencies which are just helping to keep promoting this and supporting it. I wanted to add a recommendation that you read the recent scoping review by BOLA here on disinformation literacy, because they significantly bemoaned the gap in evaluated research, and they advocate for research which informs the development, preparation of practical evidence-based guidelines, recommendations and resources to support educators and to support librarians. They particularly urge that research and programming must attend to the needs of adults outside of formal education and draw on the librarian's integral role in communities. And that's part of whether you're part of a university, whether you're as an anchor employer, whether you're a public library based in the heart of your community, a charity, and so on. It's really key to be thinking about the integral role you have and the trust with which you are held. This seemed a good point to flag Health Literacy UK, which is one of the several organisations relevant in the field. It's a community interest company, but really committed to research and trying to influence policy. So, of course, libraries can strengthen their collections. They can improve access to health and patient information, robust information that way. They can enable access to information. They can include high quality content and make sure their selection allows for that. As teams need themselves to identify our own health literacy skills, our ability to use tools like Chunk and Check or Teach Back with people and to convey those tools, helping people find reliable, trusted information. I'm sure there'll be other sessions on this through, and especially to recognise misinformation, which is becoming more and more difficult. Raising awareness, offering training, sharing practical techniques, and certainly in the public sector, providing the digital, the digital access, the kit, the caboodle, the connectivity in the first place before we get any further. So a reminder then of the core work of public libraries in the UK. Universal offers relate to health and well-being and to digital, and we know that those libraries, and there's work done by Arts Council of England demonstrating the way in which libraries, public libraries, contribute to reducing health and social and economic inequalities by promoting healthy living, by providing support for self-management, opportunities for children and adults to learn some of these skills, and of course by being effective in signposting to services and information. Librarians make great partners, they make great friends. In my case, it makes quite a great husband too, actually, but great friends and great partners. And we're very good at forging strong partnerships. Not sure we always ask enough, and I'm not sure we always ask enough for recognition for our contribution, or make it blatant on every website, place, page that we're at. So that's just the other side of that. But we do make great partners, and one of the ways we do that is by welcoming healthcare teams into the premises in which we're working, getting involved in projects of all kinds. But I really would like to push this concept of becoming a health literate organisation. Now, there's an organisation, there's an example there from Staffordshire. I was there last week as Sue Ball, who some of you might know, has just retired. They brought in an external consultant to work with their staff to understand what health literacy is, to look at how they and their volunteers, very important in the public sector, could support people to be more health literate. And alongside signposting and promoting resources, they've established health champions who can advocate for the work that they're doing, encourage health and well-being, and they've developed a framework, health literate libraries framework, that the champions can map what they're doing against. So really good stuff going on there. So I mentioned that I chair the National Health and Digital Literacy Partnership. You can see the partners across the top. Arts Council England, Libraries Connected, NHS App Team has just joined, Scarrow has just joined. And for CILIP, for which I'm the immediate past president, supporting learning, literacy and social mobility is obviously a key theme. So we want more and more people to get involved with this work. And you can see some of the things we've done. But if I focus on those goals, first of all, establishing a community-based approach that can last. I didn't want another project. You know, Matt Hancock said many things, but one of the things he said was that the NHS had more pilots than the RAF. So, you know, less pilots, more let's just get on with it. There is enough work telling us that this needs to be done and for us to test it and get on with it. We take an iterative approach. We wanted to support everyone everywhere, and we want to ensure that no one is left behind. And we've done a massive amount of work with no money through pooling our resources and sharing resources across the system. I can talk about those projects if anybody wants to catch me later. I'm here for the conference. Massive range of resources. Health Literacy Toolkit identifies resources and where there are gaps. Easy reads, health literacy, e-learning. They've all been available. They are all available to each of you. They've already been cascaded through NHS libraries, through those network of health ambassadors and via our pilot sites. As I say, Ruth Carlisle's doing a webinar on this. So look, there's a key issue here about collaborating, making the most of our skills, making the most of our assets, making the most of our collateral, our learning programs. I'm listing here some of the organisations that you might also want to connect in. There's a lot of people working in this field, and that's a great thing, but it does create an immediate problem around coordination and being able to optimise what's there. I encourage you to use the resources, of course, on the Information Literacy website, brought to you by the CILIP Information Literacy Group, all of yourselves in LILAC. Many of you will be familiar with the work of MILA, the Media and Information Literacy Association, and of course, you know, wanting us to be able to fully engage with media for connected lives safely and healthily, critically and actively. You may not be aware of the Health Information Integrity Network, which launched in February to counter harmful health information in the media online and in social media. This is open to academic experts, communications professionals, NGOs, charities, everybody, companies. So I began today reflecting on my journey through several stations actually on the way here, and I want to leave you thinking about how you, each one of you, can help vulnerable people in your community to mind the health literacy gap. I'd like each of us to do what we can against any one of these 9 things, the more the better. Raise awareness of health literacy as a determinant of ill health. Upskill staff and volunteers with knowledge and practical techniques. Target your efforts, use the geodata. Co-design, share, all the rest of it. Upskill individuals, ensure that the information and health information your organisation produces meets the need. As I say, organisations becoming health literate, work with each other, and don't forget to measure your progress. You know, it's not enough to make ourselves feel good. We have to know that what we're doing has made a difference. So as I close, let me reiterate, health literacy is a stronger predictor of an individual's health than all those other things I talked about, income, employment status. Our information environment needs to be understood as a social determinant of health and addressed within policies to address inequalities. And poor levels of health literacy place a heavy burden on individuals and the system. But we have seen that we can make a difference. So my call then is to ask you, whatever you're going to do in the next days, the next 3 months, the year ahead, towards improving health literacy, put it on your action list as you leave conference. Together we can make a difference.
Thank you. Thank you so much, Sue. That was wonderful. I'm sorry we're a little bit late getting started. So we are going to only have time for one question, which is actually quite devastating because there's loads of fantastic questions have come in throughout the presentation. Sue will be here for the whole 3 days. So if you do want to have a chat with her about anything that she's mentioned today, I'm sure she'd be willing. So we're just going to take one question from what came in. And that is a very general one about, do you feel with all the initiatives that are in place now, do you feel that there is hope for improvement, particularly on the organisational side of awareness of health literacy?
Yeah, broadly, I'm an optimist about those things in life. There are bad days. Yeah, there's always hope, because actually I'm really struck by how much, as I was preparing this, if I'd given this last October, NHS Confederation wouldn't have published anything. I'm not sure NHS England had anything quite as nice on its stage, and I'm sure I commend my former team for helping it get there, but also their NHS app team is very cute on this now. And we didn't have, the draft guidance coming out from the government. So I think this is being notched up. But, I've weighed national service frameworks and other strategic documents and given them a BMI. I've seen how high they are and how fat they are and measured their general weight and health. So we must never take the stuff for granted that this is going to be okay. But I do think more audiences, more senior staff are encouraged. And I do believe that every one of you could go back and think in your own organisation, where appropriate, whether it's a health literate organisation, but always how accessible it is to people with low literacy, on what the issues are about that, because this is definitely a spectrum. So I am optimistic, but only if you will go back and agree with me and do something about it. It's a team game.
Wonderful. Thank you so much, Sue. We won't keep you from lunch anymore, but a big round